And this morning we're going to discuss the impact of critical illness on the respiratory pump. And I think it's important that this is meant to be a kind of tutorial. So please interrupt me anytime you wish. If you have questions, if you do not agree, if you have comments, do not hesitate to interrupt me. We're a relatively small audience, so no problem at all. Or maybe first I should ask you, what do you really want me to address or want to discuss with your colleagues in this next 30 minutes? Is there burning items related to this topic that you would like to discuss? Nothing? Then we just go ahead. But I don't want you in the end to say, well, we haven't discussed this and I was expecting this and this. Okay. So these are my disclosures. I don't think there's anything related to the current presentation. So what I would like to do is to discuss the impact of the critical illness on the respiratory pump, diagnosis of diaphragm respiratory failure in ICU patients, and see if we can improve respiratory muscle function in our ICU patients. Again, this should be an informal session. So the respiratory pump. This is what I love. This is this fantastic dome-shaped muscle that upon contraction decreases alveolar pressure and maintains alveolar ventilation. And keep in the back of your mind, this very important muscle has a thickness of only like 2 millimeters, right? It's really amazing the job the diaphragm does. But also keep in mind that the respiratory pump is much more complicated. There's a lot of inspiratory muscles, the most important the diaphragm, but the expiratory muscles contribute to alveolar ventilation upon high loading as well. And the most important muscles for expiration are the 3 lateral abdominal wall muscles. So as you're sitting here, how much pressure can the diaphragm generate? Do you have any idea? The maximum inspiratory pressure? 100 centimeters of water. So how much do we need for alveolar ventilation? How much pressure do you generate right now with the diaphragm? Very little, 5-6 centimeters of water. The compliance of your respiratory system is close to 100, right? So if you develop a pressure of 5 centimeters of water, tidal volume is 500 ml. So the diaphragm has a huge reserve capacity. Again, maximum inspiratory pressure 100. We only need 5 centimeters of water for alveolar ventilation. Still, respiratory muscle weakness is important. And I think this is a very famous picture by Samir Gerbert and colleagues showing that after like 3-4 days of controlled mechanical ventilation in the ICU, the pressure generating capacity of the diaphragm has decreased by 25%. So you're losing your inspiratory strength really fast in ICU patients. And this has a clinical impact. We all know that patients with respiratory muscle weakness are more difficult to wean from the ventilator, have a higher risk of ICU readmission and higher risk of mortality. So this is a nice observational study by Alexander de Moule, Martin Dress from Paris. They tested peripheral and respiratory muscle strength at the time of awakening on the ventilator. And they found that like 63% of the patients ventilated for at least 48 hours developed inspiratory muscle weakness. And of these 63%, 2/3 also had peripheral muscle weakness. But this is important. I mean, it's not always that if you have diaphragm weakness, there is peripheral muscle weakness, or the other way around. They appear to be different entities. So a patient can be strong in the peripheral muscles, but still have respiratory muscle weakness. So this slide very concisely summarizes the pathophysiology of diaphragm weakness in the ICU patients. And there is an important role, and I think a very important role actually, for systemic inflammation, sepsis, infection. I think if there's no sepsis in your ICU patient, no infection, the likelihood of really developing respiratory muscle weakness is not that high. So that plays an important role. But it's not something that we can really modify, right? I think the thing that we can modify is mechanical ventilation. Excessive unloading, controlled mechanical ventilation, of course, results in disuse atrophy. You lose muscle mass. But on the other hand, and I think that's getting more and more interest in the literature, if there's insufficient unloading, too low level of inspiratory support during assisted ventilation requires the diaphragm to generate a lot of pressure to maintain alveolar ventilation. And I'm going to show you in a minute, this may result in load-induced injury of the diaphragm, what we call sarcomeric disruption and such diaphragm weakness. Does this make sense, or you think, well, okay. So this is a study we published a couple of years ago where we took biopsies of the diaphragm of real ICU patients. So these were patients with sepsis or whatsoever in the ICU and a clinical reason for thoracotomy or laparotomy. So we asked the surgeon to take a biopsy and we performed in-depth analysis. And yes, as expected, we found atrophy of diaphragm muscle fibers, probably related to disuse, inactivity. But I think what was more intriguing, more interesting, it is not just atrophy. There was infiltration with inflammatory cells, macrophages, lymphocytes into the diaphragm. And this is not just consistent with atrophy. Moreover, if we took like electron microscopic pictures, you will recognize the normal striation of a muscle right here. And this was quite typical in ICU patients. Complete loss of the architecture. And this is not seen in patients in just disuse, inactivity. So this is probably, but I'm a little bit careful here, but this is probably more consistent with load-induced injury. So how does mechanical ventilation affect the diaphragm? Well, there's at least two things. Over-assist, under-assist. Could other factors play a role as well? Have any idea? Well, it's quite hypothetical, and it's the topic of investigation. So this is the disuse atrophy. This is the load-induced diaphragm injury. But there could be eccentric injury. Eccentric injury means the muscle is contracting, but lengthening at the same time. And that could develop during poor patient-ventilator interaction. If the ventilator cycles off, there's expiration, expiratory flow, but the diaphragm still contracts, it may result in eccentric injury. And actually we're looking in that right now, and it's not even that difficult. Eccentric injury appears to develop quite a lot. And there's other mechanisms, I've discussed that in more detail yesterday, that's a so-called longitudinal atrophy. The application of PEEP changes the geometry of the diaphragm. It results in a downward movement of the diaphragm, making the diaphragm shorter. The diaphragm adapts, and then if PEEP is released, the diaphragm is overstretched. It's an interesting mechanism, but it requires much more, well, research before we really can confirm it plays a role in clinical practice. Okay, so this was the concept we have on so-called diaphragm protective mechanical ventilation. And I think it makes sense, like the previous presentation where the presenter said, well, we are looking for the normal blood pressure targets for our patients. And I think in a patient on an assisted mode, we are looking for a physiological breathing effort. And that's what we call diaphragm protective mechanical ventilation, prevent, over and under assist. But that requires actually assessing, quantifying respiratory effort in our patients, right? So let me just ask, who's actually measuring respiratory effort in your ICU patients? Professor van Zanten does, I'm sure. So, any other people? Nothing? So there's work to be done, because I think it is important, and I'm sure that a couple of you are actually doing it. And there's different techniques. And I know that, well, the esophageal balloon is like the Swan-Ganz catheter for the hemodynamics. I think it's really the state-of-the-art technique, but few people are using it. And I don't think in most of your patients you don't really need it. There's good alternatives. Airway occlusion pressures, diaphragm ultrasound, EMG perhaps. We're going to briefly discuss this. Anyone experienced with the esophageal balloon at all? Not that much? You do? Okay. So it's actually the technique is not that difficult, right? The balloon costs you like 40 euros, 50 US dollars, something like that. So it's not really expensive, and it will provide you a lot of information. So during inspiration, pleural pressure decreases, and the decrease in esophageal pressure actually is an estimation of the change in pleural pressure. So right here, in a patient, during inspiration, there's a decrease in esophageal pressure, and this change in esophageal pressure reflects more or less the pressure that is developed by the respiratory muscles. So if this change in pressure is 5, you would say this is in the physiological range. If this is 30, the patient probably has a very high effort that might, I'm careful, that might be damaging to the diaphragm. The problem is, and even in our ICU, where we are quite, well, familiar with the esophageal balloon, a lot of people are not using it. So we are looking for more non-invasive ways to assess breathing effort and respiratory drive. And in this paper that was recently published in Anesthesiology, we did quite extensive validation of P.1 and the so-called occlusion pressure. So the P.1, I guess most of you are familiar with that, is the decrease in airway pressure during the first 100 milliseconds of inspiration. It is, I think, more or less routinely assessed by every modern ICU ventilator, and it was already described like 40 years ago, so that's nothing really new about it. And in this study, and I'm not going to go into detail, it's not really the topic of this presentation, I think that P.1 can identify patients with a low breathing effort. So if the P.1 is really low, it's very likely that you're an over-assist. But on the other hand, the P.1 is not very good in identifying patients with a very high breathing effort. So as an alternative that's much better, and also like feasible in clinical care, is a single occlusion pressure. So right here, patient on pressure support ventilation, pressure flow. This is the esophageal pressure, just to demonstrate. There's an inspiratory effort, and right here I just perform a single occlusion. So the patient takes a breath, he's not expecting a halt. There's a decrease in airway pressure, and a decrease, of course, in esophageal pressure. And the decrease in airway pressure is more or less the same as the decrease in esophageal pressure. So you don't need the esophageal pressure for this. What we actually found in this study, and my PhD students actually analyzed like 800,000 breaths, so we're quite confident with the data, that if you want to know the pressure generated by the diaphragm, you just multiply this occlusion pressure by 0.71. And you have a good estimation of how much pressure the diaphragm develops, with very nice areas under the curves, and I think it's right here, a very good performance. So, if we can agree that the physiological activity of the diaphragm should be between 3 centimeters of water and 12 centimeters of water, that's what we agreed is more or less the physiological range. That is what the effort your diaphragm is generating at this moment. If we can agree upon that, and we can discuss that for 2 days, but if we can agree upon that, then you'll see that the performance of occlusion pressure is really nice. So if you say that the occlusion pressure should be higher than 7, the accuracy is 92%. Same thing for the accuracy of the occlusion pressure to identify patients with a transdiaphragmatic pressure higher than 12, we're using a cutoff value of 15 for the occlusion pressure, and also the accuracy is pretty high. Again, the esophageal balloon is better, but in most patients you don't need it. You are able to identify by a relatively simple occlusion, identify patients with low or high effort and maintain the so-called diaphragm protective ventilation. Okay, just going to skip this. But again, this is important. I mean, the reference values are more or less by consensus. They are based on physiological principles, but have not been really validated in severe ICU patients. So to conclude this first part, I've shown you that diaphragm weakness is highly prevalent. It has clinical implications. There is really a role for ventilator over-assist and probably for ventilator under-assist, and other mechanisms may be at play, but really, honestly speaking, I don't know the importance of these mechanisms right now. So how do we diagnose respiratory muscle weakness in our ICU patients? And I think it's important. I mean, if we do have patients that fail a spontaneous breathing trial or fail extubation, there's actually quite large differential diagnosis, and in this simple paper we've reviewed that as the ABC of weaning failure. The reasons for failing a spontaneous breathing trial could be at the level of the airway, lung, could be at the brain, cardiac, diaphragm or endocrine. That's our ABCDE as written in this paper. So just as a question, how do we know that a patient has actually diaphragm weakness? Any tests we can do? Ultrasound, yeah? Anything else? Physiotherapists in the room? I'm sure you're doing it. Exactly, yes. To assessment of diaphragm strength, state of the art, but few people are using it. I mean, even in our ICU, it's exceptional. Magnetic stimulation of the phrenic nerves and measuring either transdiaphragmatic pressure or just occluding the tube and measuring change in airway pressure. It's really the state of the art, can provide a lot of information, provides information of the integrity of the phrenic nerves, but I think it's very limited use. It's not very practical, but much more simple. If a patient is cooperative, just measure a maximum inspiratory pressure. As we discussed before, reference value, around 100 centimeters of water. Well, very, very, very few patients in the ICU will develop 100 centimeters of water. But if the value is higher than, say, 40 centimeters of water, I think it is unlikely that respiratory muscle weakness explains failing a spontaneous breathing trials. Probably something else is going on. But the patient has to be cooperative for this technique. Ultrasound, of course, I think it's very helpful in assessing the function of the diaphragm or other expiratory muscles, and we have reviewed that in this paper published like 2 years ago. Very simple. If you just take your ultrasound probe, take the liver as a window and look at movements of the diaphragm. So right here, you'll see the liver, and on top of the liver, this is the diaphragm. And if I start the video, yeah, right here. So during inspiration, diaphragm moves towards the probe. Deep inspiration, diaphragm moves more towards the probe. If you see something like this, it's very unlikely that the patient has severe diaphragm weakness. I mean, this takes you like 3 seconds, right? So I think it's really helpful in a patient failing a spontaneous breathing trial to assess movement of the diaphragm. What is very important, of course, that the patient is disconnected from the ventilator. Because a patient on volume-controlled ventilation, neuromuscular blockers, the diaphragm will move downward as well. So the patient should be disconnected to the ventilator or at least without inspiratory support. So these are the reference values. The other thing you could do is looking at thickening fraction. I mean, every muscle that contracts thickens, right? So if you take the linear probe, put it in a mid-axillary position, It will be easy to identify the diaphragm here between the peritoneal and the pleural line. This is the diaphragm. And if I start the video, you'll see upon inspiration, the diaphragm thickens. And you can do this with a little bit of support. I mean, if it thickens, it means the diaphragm is active. So it gives you a semi-quantitative view of whether about the function of the diaphragm. But, I mean, people have said in the past that thickening fraction is very nicely related to pressure generating capacity of the diaphragm, and that appears untrue. Actually, for ICU patients, there's a very poor correlation between thickening fraction and the pressure developed. So you can use it as a diagnostic tool. Is the diaphragm active or not? Does it have a reasonable strength? But you cannot say it's developing a pressure of 40 centimeters of water. I'm going to skip this. So if a patient is weak in the ICU, it is not necessarily ICU-acquired diaphragm weakness. There's always a differential diagnosis, right? In your life's ICU, every year you have a couple of patients that present with respiratory failure, and then the underlying cause appears to be a myopathy, ALS, multiple sclerosis, or whatsoever. So always keep a differential diagnosis in the back of your mind, especially if a patient has severe respiratory muscle weakness and did not have any sepsis at all. Okay, so this is important. How can we improve function of the diaphragm or the respiratory muscles? Anything? Or just sit and wait? Okay, I'm sure you know the answers. So this is quite disappointing. I mean, for cardiac failure, we do have quite a lot of different drugs to improve cardiac function, right? Respiratory failure, today nothing has been approved to improve respiratory muscle function. But I think there's things coming up. The most important thing, I think that quite a lot of you will actually do in your ICU is inspiratory muscle training. So who does actually have experience with inspiratory muscle training? No one? Okay, so it's good to think about it for a little bit, because the diaphragm is more a muscle for endurance and less so for strength, right? Remember, we can generate 100 centimeters of water. We only need to generate 5, 6, 7. So it's not really a muscle for strength, but endurance. Do we do endurance training? Well, we do progressive spontaneous breathing trials, but the effect of endurance has never been demonstrated. It feels good if we're doing it, but I'm not sure if it's really going to improve endurance. On the other hand, if your maximum inspiratory pressure is 35 centimeters of water, does it make sense to perform strength training? Again, you only need like 10 centimeters of water maximum to maintain alveolar ventilation. And still, I think it makes sense. And this is a really interesting study published, well, 40 years ago. Healthy subjects, students, performed inspiratory muscle loading. So there was an inspiratory resistance, and they graded their dyspnea score. Well, the more resistance, the more dyspnea. But now they did the same, but with a little bit of neuromuscular blockers. I think it would be difficult to do these experiments today with the ethical committees, but in the 80s, it was possible. So, and the interesting thing is, if you develop respiratory muscle weakness, in this case by pharmacological modulation, the same load results in more dyspnea sensation. So if this is true, it makes sense to improve strength in our ICU patients. Oops. Okay, I'm going to skip this. So there is a couple of studies that have evaluated the effect of inspiratory muscle strength training in ICU patients. So this is a very nice study by Daniel Martin, patients that were on the ventilator already for 46 days. IMT was applied for like 5 days a week, maximum 28 days, together with breathing trials. So what they found, so this is the sham group, inspiratory muscle training group, that inspiratory muscle training indeed improved inspiratory muscle function. So in these patients, the inspiratory muscles could generate more pressure and, but this is not the primary endpoint, they were more likely to be weaned at day 28 from the ventilator. This is a study published earlier this year, 2022, basically the same outcome. They demonstrate that with inspiratory muscle training, a little bit of a different protocol, that it improves inspiratory muscle strength, and he also found as secondary outcomes that it improved weaning success and even mortality. But there's limitations because being a single center study. Okay. So I think there is a role for inspiratory muscle strength training in patients that fail weaning from the ventilator and are actually weak. Questions about these topics or concerns or different views? Yes, please. Sorry? Okay.
Training involved.
So the practical aspects?
Yeah, how's it done?
So, I mean, the simplest way is just use this disposable device. You can connect it to the endotracheal tube, you can connect it to the tracheostomy tube, and there's different protocols out there, like 40% of their maximum inspiratory pressure, that's what they did. So 4 cycles, 10 threshold loadings at different pressures. And I think that's one of the weaknesses. We're not aware of the optimal protocols right here. But I think that is reasonable. We are using this protocol. I mean, it has been used in the study. It has shown favorable outcome. But I'm not sure, because I've talked to the author, it's a quite pragmatic way how they did it. I'm not sure if it's the best way. But if you want to use inspiratory muscle training, I think this is reasonable. The other study I showed you, they used this more advanced strength training device. I think it's called the power breath. It's a little bit different technique. I'm not sure if that's really going to make a difference. You just want to impose a kind of strength upon the muscles, right? And I'm not sure if the technique matters that much. Other questions, concerns?
Maybe I can ask a question, Leo. Thank you for your presentation. Excellent. Does expiratory muscle recruitment and relaxation play a role in the measurement of the occlusion pressure during spontaneous breathing?
So during the occlusion pressure, no. I don't think that
It doesn't make the reading very different if you relax before the measurement.
It's a good point. I don't think that much. It could. Theoretically it could, but I don't think it has a large role in the measuring the occlusion pressure. If you're using, and I haven't really discussed that, one of the other techniques, the PMI, the pressure muscle index, then the role of the expiratory muscles is really important. A little bit less so in the occlusion pressure. But you are right. I mean, if a patient is using the expiratory muscles and relaxes at the beginning, part of the drop in esophageal pressure results from the relaxation of the expiratory muscles. Yes. Other questions?
What about nutrition? Do we know something about protein intake or something?
Yeah, well, the expert, Professor Van Zanten, is over there. The only thing I would like to show you as a final point, and I think that's, so this is interesting. They're now developing, and studies have been published on diaphragm pacemakers, either implanted through laparoscopy or, more interestingly, connected to a central venous catheter that can be inserted to the jugular vein. That's a so-called lung pacer. And these kind of devices actually limit development of diffuse atrophy, improve diaphragm strength or maintain diaphragm strength, but do not affect clinical outcome, at least not in these studies. But I think this is a promising technique in addition to inspiratory muscle strength training. I'm going to skip this. So I think this is an important area, the role of, I got 30 seconds, no. So I'm just going to say this is a very nice study by Annemie Scholz, published quite some time ago, and this is not in ICU patients. This is in patients in rehab for severe COPD. And she demonstrated that the combination of anabolics and high caloric feeding can improve inspiratory muscle strength. Not just the anabolics, but the anabolics together with rehab, together with high caloric feeding. And I think, and this is a nice review published 2 years ago, that also discusses the role of the combination of inspiratory strength training, of anabolics and adequate nutrition. And I'm not sure of precise protein targets for these patients, but at least adequate feeding can improve inspiratory muscle strength. And if you're interested in this, I think this is a very nice review to actually read, and they discuss the different anabolics that could be used for this. And this is my final slide. So the pathophysiology, it's not just disuse atrophy. Keep that in the back of your minds. So prevention, very important. The so-called diaphragm protective ventilation. And the treatment of weakness, well, I think most evidence out there is inspiratory muscle strength training. And I think there's emerging therapies. The lung pacer, I think the anabolics, and perhaps some inotropes that we are developing. Thank you very much.